Welcome, everyone, and thank you so much for joining us today. I'm Rachel, I'm the Chief Executive of the Patients Association, and today's session is titled, Do Patients' Goals, Values, and Preferences Really Shape Their Care? It's a question that might sound pretty straightforward, but the honest answer for too many patients is no. Our own 2026 patient experience survey found that just 2 in 5 patients felt like genuine partners in their care. And over the past decade, the proportion of patients reporting that healthcare professionals are involving them in decisions about their care has actually fallen. So today we want to explore what's getting in the way and what good looks really like. And I'm going to let the panel introduce themselves. And I want to make sure that as part of the conversation that we have today, the patients are at the center of this, which is why it matters so much the patients are in the room with us today as well. So let's get into our webinar, and I'm going to hand over to Mahammad and ask you to introduce yourself. Is that okay, Mahammad?
Of course, yeah. Thank you, Rachel. Hi, everyone. Thank you for having me in. My name is Mahammad Osman. I'm based in Sheffield, and I'm assistant youth worker. I work in a charity that works with young refugees and asylum seekers. So I had like a long experience with the health system through like my personal experience and through my client as well. Yeah. Nice to meet you all.
Lovely. Thank you. And Alyson.
Thanks. I'm Alyson Thomas. Rachel, can I just check, is this where we take our 6 minutes or just
Yes,
say
please.
hello at this stage? Lovely, thank you. So I'm Alyson Thomas. I'm Chief Executive of Llais, which means voice in Welsh. We are the independent statutory people's voice body for health and social care in Wales. And our role is to listen to people across all our communities in Wales and use what they tell us to influence how services are designed and delivered by working with health and social care decision makers. A core part of our work is our free-to-use complaints advocacy service, where we support people to raise concerns about their care and help them navigate what can be an incredibly complex system. Through that work, we hear directly from people when things have gone wrong, but also what they wish had been different, what would have helped them feel more listened to, more involved, and more respected. Alongside that, we engage with people more broadly. We listen face to face and online. So we operate across all parts of Wales, where people are in their communities, and we also visit services to hear from people whilst they're accessing those services. What we hear is often really consistent. People don't just talk to us about treatments or outcomes. They talk to us an awful lot about how their care feels, whether they were truly listened to and involved, whether the system worked around them or whether they had to work around the system. And I think that brings us directly to the question we're exploring today, is whether people's goals, values and preferences genuinely shape the care that they receive. And I guess from what we hear in Llais, the answer is sometimes, but not consistently enough. We hear some really powerful examples where people feel genuinely listened to and involved in decisions about their care. And when that happens, it can be really transformational for them. They describe feeling more confident, more in control, and more able to manage their own health and well-being. But just as often, we hear when people don't feel that their voice is shaping the decisions, and where people feel that they are being moved through a system rather than being genuine partners in their care. So that's why in Wales we've been working to bring together what people across Wales have told us matters most through what we've called a national conversation that's involved thousands of discussions and voices. And I think at the heart of what we heard through that project was a really simple message, which was people want to be treated as human beings, not as cases or numbers on a list. And so from what we heard through those conversations, we developed what we call the People's Principles. So they're a set of 8 expectations that describe what people told us good health and care looks like from their perspectives. So they include things like access to health and social care services that works for everyone, dignity and respect every time, clear and honest communication, joined up care. We hear that all of the time. Recognizing me as a whole person and not just my condition or circumstances. And services that are inclusive and fair. That came out an awful lot through our discussions. So I guess what's important for us about those principles is that they focus on how care is delivered and not just what is delivered. Because people tell us all the time is that their whole experience matters and not just the clinical outcome of their treatment. And when we look at where care is falling short, the gaps are often in those aspects, those experience aspects. So, for example, people tell us they don't always get clear information about what's happening with them in their care or what their options are. They often feel they have to repeat their story or find themselves having to navigate across services themselves. Many talk about long waits with little communication or support while they're waiting. And these things aren't small issues. They affect whether people feel able to take part in decisions that affect them. Because if you don't have clear information, if you don't feel listened to, if you don't understand what's going to happen next, it's really difficult to be an equal partner in decision making. So one of the other things that we've been focusing on in Wales, and we're really pleased that the new government that we have in Wales has committed to this, and that's to introduce what matters to you conversations in the NHS. So making sure that the time is taken to understand what's important to a person and just not just what's the matter with them clinically. And for us, I think that's a really important shift because it moves us from a model where decisions are made for people in a kind of paternalistic way to one where decisions are made with people. So it highlights that this isn't just a matter of policy or process. We're talking about a culture here. So the question then becomes, I think, how do we move from knowing what good looks like to how do we make it the norm? So the people's principles for us are one way that we're trying to do that. So we're working with organisations across Wales through partnerships, pilot work, and through a People's Principles Alliance to put these expectations into practice and to help create a shared understanding of what good looks like across all parts of the health and care system. So, for example, that's about using the principles practically as a design framework when you're developing or reviewing services, embedding them into quality and improvement conversations, using real people's stories and experiences to test whether services reflect what matters to people. And I guess creating space for staff to have more meaningful conversations rather than just transactional interactions. Because what we want is a different kind of conversation, one that starts with, as I said, what matters to you and not just what's the matter with you. If we get that right, then shared decision making becomes much more real. So I think as we kind of move into the discussion today, the challenge for all of us is we know what goods look like generally. People have told us certainly.
Have we lost Alyson? I think she may
Our
have
voices, and those voices genuinely shape decisions. That builds trust and creates a system that works more effectively for everyone. Thank you. I hope I haven't gone over time.
No, that was absolutely brilliant, and that what matters to you is so important. Seb, I'm going to come over to you now. If you can introduce yourself and give me your views on the world.
Of course. Thank you. Thank you so much for having me. I'm always very happy to get involved in what the Patients Association is doing, and particularly at what I think is a really crucial time for patient voice, patient engagement, and for our health system. So very glad to be here. My name's Rees, for those of you I've not met. I am the head of health at the Institute for Public Policy Research. And for those of you who don't know what the Institute for Public Policy Research is, we are a progressive think tank. We work across all areas of public policy, but we for a long time had a real focus on health and care. And currently, and very relevantly to this conversation, a lot of our attention at the moment is going to how we truly shift the balance of power in our health system away from providers and towards patients, their families, and communities. Some of you may recognize me on this call, and the reason for that is before I joined this job, I worked at Healthwatch England. And my time out of the patient engagement space over the last year and a bit has given me, I think, a good opportunity to reflect on kind of what we get right in this space around patient engagement, what we sometimes get wrong, and also where we need to go next. So really looking forward to kind of sharing thoughts and discussing those points. I always feel bad watching a panel discussion where the question on the slide doesn't get answered. So I'm really glad that Alyson has had a really good stab at that. But I will also do my best to add it directly, to answer it directly. So the question is, do patients' goals, values, and preferences really shape their care? I think the honest answer to that question is no, not yet, not consistently, not for everyone. And most of the conversations we have, I think that would ring true, but we can also see it in the data. So the Patients Association's own work shows that only around 2 in 5 patients feel like genuine partners in their care. And unfortunately, the proportion of patients who say that that the person responsible for providing their care involves them in decisions, has been falling, not rising over time. We also know from the GP patient survey, a huge set of data on this, that in general practice, where a lot of these conversations really need to be happening, that it's not consistently the case that patients feel involved. So the GP patient survey, after many years of pushing for it, now includes a question to patients with long-term conditions or illnesses about whether they've had a conversation with a healthcare professional about what matters to them in managing their condition or illness, and just 4 in 10 people say yes to that. So less than half of all people with a long-term condition say that their healthcare professional, their GPs, involve them in a conversation about what matters to them. And of that, it's actually slightly more than 4 in 10, 42% of people, of that 42% of people, less than half, 45% of them, say that conversation that they've had about what matters to them has been then reflected in a plan around their care. And we also know there's lots of inequalities baked into that. So people who are older, people who provide more than 20 hours of unpaid care a week are less likely than average to say that they've had a conversation with a healthcare professional about what's important to them. So answer the question, no. What does that tell us? I think what it tells us is despite decades of us talking about shared decision-making, patient activation, patient voice and engagement, we've really struggled to shift the dial on power. And ultimately, this is a conversation about power. It's a conversation about who holds power in the system, about whose expertise counts, and about whose goals really set the agenda. Right now, systems really ask patients to fit around the goals that they set and the agenda that they set, whereas real partnership would involve flexing the system around patients. And that obviously matters to all of us, but it particularly matters to people who find it very difficult to raise their voice in the system. And I think we really do need to consider whether our current approach to shared decision-making, patient involvement, et cetera, works for everyone. I think it probably works quite well for people like me. I don't know if it works well for people who deal with systemic health inequalities, who struggle to make their voices heard. So I think we need to have this conversation in the round and think about the inequalities that are baked into it, as well as the overall problem that we have. How have we got here? I don't think this should be a blame game as such, and I think it's unhelpful to think about shared decision making as a competition between patients and people responsible for delivering care. And I think the way out of where we've got to is probably really building on that partnership approach, because when I talk to people providing care, they will also say that they feel frustrated by the constraints of a system in which the thing that really motivates them, which is providing good care for the person in front of them, is squeezed out by guidance, targets, an activity-based model in which what we reward is seeing more people more quickly rather than having a good conversation and doing what matters to people. So if I am going to point the finger, I'll point it at people like me, And those are people who inhabit a strange sector called health policy making. I think those of us who work in health policy often find it strangely quite difficult to talk about the actual delivery of healthcare. What happens in the four walls of a GP consulting room or in a ward round or in a discharge lounge is uncomfortable territory for us. We find it really easy to talk about things like structures, who should sit on the integrated care board, who should be responsible for managing a primary care network. We find it easy to talk about funding and who gets it and how it should be allocated at a kind of macro level. We find it really uncomfortable talking about the messy realities of delivering and receiving care. So we're obsessed with the plumbing of the NHS, but we're really incurious about what comes out of the tap. And then I think that extends not just to this conversation about how we involve patients directly in their care, but also to the patient engagement space in general. We tend to be obsessed with things like what's the right institution and structure for patient voice or engagement? How do we collect more data on what people are telling us? But we don't have enough of a conversation about patient stories and the mess that's involved in patient stories and working out what people's lives really look like. So I think there's a real problem in terms of our policy-making process that we're incurious about the delivery of healthcare and what it means to provide really good healthcare in the 21st century. I'm hoping that we have a bit of a window of opportunity to shift power in the system at the moment. I think some of the conversations we're having around things like neighborhood health, around kind of really building health into communities and the places that we live, will help us to have a better conversation with patients and the public about what we're trying to achieve and what healthcare is there for. But I fear at the moment that we're collapsing back into the wrong conversations and that we're losing sight of our fundamental purpose, which is to build a health system that genuinely recognizes and values patient preferences, goals, values, and expertise. So I'm really hoping in the next few months we have a really good opportunity to have a much bigger conversation about what it is that we're trying to achieve out of this huge amount of money and resource that we put into something called healthcare. And I think we have an exciting opportunity there. So hopefully end on a positive note.
Okay, well done for trying to end on a positive note. Mohammed, in hearing what you've heard from Alyson and said, before I go into the real questions, do you have something you'd like to add?
Yeah, of course. Yeah, I would add first thing, thank you for the Patient Association to include me in this. This kind of webinar is really beneficial and really we need these kind of things. So I just want to add about inclusive, always there is inclusion or includes different values and culture and tradition. So you also have to make space for them, room for this culture and this tradition, not just the inclusion of people from different backgrounds, also their tradition and their background and their what they believe in. So I have a lot of examples. It comes religious and culture and stuff. So I would say it's a different situation. So I sometimes have the room to explain my needs, the value that I have, or the expectation, but sometimes I don't have that room. So it's very tricky. You're always confused how much space do you have to input your values and stuff. Is it really considered? It is not. Is it not? And it's an unusual place. It's an unusual place. And you did mention communication is a big thing, what happens between So it happens to me a lot, with my friends, with my clients. When there's just a slight miscommunication, but it causes a big escalation, no understanding what's going on. For something so minor like blood test, when it comes to blood test, you will be amazed how much people have background and stuff about it. Some of them we don't like to take have blood tests. Some people don't understand what's the point of it. So I think you always have to be considered to put a space for that. And I think this is what good care for me is to include everything from your culture, to give you the space to input and how they could help you give you a proper healthcare especially for special background and stuff. Yeah.
No.
That makes sense. Yeah.
It makes absolute sense. And I have more questions for you. But before I go to more questions, I just want to run a poll so that we can see what our audience is thinking. So the poll is around shaping your care. When when you have shared your personal goals or preferences with a healthcare professional, what happened? They shaped my care plan. They were listened to, but didn't change anything. They weren't really acknowledged. And I have never done it because I didn't feel able to. So if I think people can start filling that in now. Okay, I'm not seeing any results. So maybe the amazing people in the background. Oh, I am seeing results. I knew the amazing people in the background would sort that out for that. Okay, shared all the way through it. They shaped my care plan. That was 26%. They were listened to, but didn't change anything. 39%. Weren't really acknowledged, 24%. And I've never done it because I've never known how to or feel able to. And somebody in the chat has said, I've never been given the option. So I think it comes back to Alyson and Seb, what you're talking about, power. We can close that down now. But Mohammed, I just want to come back to you. And so, you know, in that very quick survey and that poll that we did there, do you have, you know, maybe from the work that you do, and you talked a lot about culture and understanding the barriers as well that might happen. If I was to ask you a very direct question, do you feel the patient's goals are actually being considered?
Yeah, but to be absolutely honest, is sometimes it's not always being considered. I think it's in some cases and in some cases not. So for me, basically, like I did share some goals with, like, my doctor and stuff. They did like listen and they did like optimize it to get better, or like to get the goal I have. But I seen it to one of my clients. It didn't happen. Like it did have like unique set of beliefs or like cultural beliefs. So let's say, for example, let's say like mental health issues, and he was like, in his belief, in his culture, is there's nothing like mental health. There's no such thing like mental health. It's what he say, like black magic or something from that sound. So I think when he give that background to the doctor, or like to the specialist, they did listen, but they did the same like mental health, which is mental health. Like I would say, like if in a practice ways, it is mental health, but they should like consider also his input, like to try to meet him. I'm not saying like the NHS practitioners or like the specialist should know how to deal with black magic. I'm saying they should like consider his ideology or background, or and try to like, yeah, get to him and try to help him with the best way possible. So I'm not sure if it's always met. Yeah, so I agree with the two highest polling answer on the poll. Yeah.
Okay, thank you, Mohammed. And Alyson, you talked a lot about, which I think is great, that the new government is talking about what matters to you and what's important. But how do you think we can actually get that happening at a ground level when staff are working, you know, and working really hard, and most staff want to do this?
Yeah, I think for certainly goes back to the point that Seb mentioned earlier about what we value and what we measure in relation to our health and care system. So we know how important it is that people feel listened to and want to be part of decisions about their care, and that's their personal care as well as the wider decisions about how their health system operates on a whole community basis. So they want to be part of that. In our experience in Llais, when policy makers and governments want something to happen in that way, there's a few ways in which they can do it. They can legislate for it, or they can set performance measures around it, and they can judge performance on that basis. That certainly gets services responding and focusing on that area. So we need to make sure that we create the conditions that enable and support healthcare professionals to understand the importance of involving people and being a true partner in their healthcare. And we need to have arrangements in place that monitors, measures that, and recognises that when it happens.
Yeah, brilliant. And Seb, is there a problem with how you talked about commissioning and funding, and is there a problem with the way that we measure outcomes for patients? And if we did measure against outcomes, would that have a better impact on this?
Yeah, I think there's kind of two problems in this. The first is the what do we measure question, and I don't think that we do a good enough job at systemically measuring whether or not people's care meets their needs and whether or not they've had a conversation about their goals. The one way in which we do measure that is through something like the GP patient survey. So we have some data on this. I think there are areas in which we should and would like to measure more. So the obvious example would be something like patient activation. We've kind of gone around the houses for many decades on having patient activation scores. And often the pushback that you get, particularly in national policy making circles, is to kind of make things too complicated. Like, well, what about this? And what are the things that you're missing out on? We hold the kind of patient activation measure to a much higher standard than we would other measures of healthcare outcome or activity. I think it's having really simple measures, and what we'd say like longitudinal measures, so things that you can look at over time and say, is this improving? I think there's a lot of work to be done in that space. I think one of the problems with, again, the approach to measurement is we also have to be brave in saying this might mean that we measure less of other things or we care less about other things. And I think we should be open to a conversation in things like QOF, so the Quality Outcomes Framework, where GPs get a little bit of their additional resource in England about maybe being less obsessive with process measures on a huge number of clinical things, and being comfortable with saying, actually, we would put activation right up there as something that we care about. So there's a kind of what measures question, and then there's the accountability question, which is, has anyone ever been dragged over the coals because it was found that they didn't listen to patients in their practice? Not really, but if the finances go or there are too many referrals to secondary care, those are the kind of things that people are held accountable on. So I think you need to couple the measuring what matters to patients with some genuine accountability about where people fall short. And that doesn't have to be people lose their jobs or funding is withheld, but I think it has to be an honest reckoning with the fact that there is a huge amount of variation on some of these measures at the moment. And there are some practices and some systems or some areas that do a lot better on this than others. I think that can actually be an opportunity to share some learning in this space. I think one thing that's interesting here is we quite rightly have a conversation about not having a one size fits all approach, not making this too standardized, but there is a toolkit and there are ways in which you can make a difference to this. And I think some of the use of the data to say, why is it that if we look at that question in the GP patient survey about whether people had been involved in their care, in one practice, 80% of people say yes. In another practice, 10% of people say yes. I think some of those questions about using that data for quality improvement purposes, I think that's kind of quite a fertile ground for improving services. So yeah, measure better, hold people to account, and also use the data that we have on this to really drive shared learning, I think would be my plea.
Brilliant. That's really helpful. And Mohammed, so imagine a place where one of the clients that you work with have really had their goals and preferences listened to you. What difference do you think that would make to that person?
I think it will make a lot of difference, huge difference, especially when they already been going through like uncertainty or like a huge amount of anxiety and tough like hardships. So I think this will shift a lot of the way from their back and make them like feel better or feel also welcome. If it make them feel welcome, if it feel respected in the community, make them feel like a lot of aspects because when you care for someone's health or well-being, it's a huge thing, like it's a huge part of their lives. Yeah.
Brilliant. Do you think that it would make living the rest of their lives? So I think it's what Alyson, you said, we are more than our conditions, we are whole people. Do you think that would have an impact on everything else within their lives?
Of course, yeah, yeah. Especially when it comes to integration and the look to the community, like they will feel like we're very welcome. We have the space, we have the recognition, and it just reassure them that they belong there. Like we like have acceptance, welcoming, protected here. So yeah, it affects a huge thing in their life, like in their future and how they could thrive and how their children could thrive. Like they will receive also proper care. It's huge thing. It's massive. Yeah.
Alyson and Seb, somebody's put into the chat about the time that healthcare professionals have. And when we did a study on shared decision making a number of years ago, we really questioned, GPs are working with 10-minute appointments and they have to do so many things. Do you think that that is an issue in really doing that shared decision making and that what matters to you?
Sorry, can you come again? Like the GB needs to do what?
I'm saying the GP needs to do so many different things within that 10-minute appointment. And I am talking about GPs here, not because, and I'm just asking Alyson and Seb as to whether that time limit is a problem in terms of doing shared decision making and doing the what matters to you.
Exactly. Yeah. To be fair, I'm not blaming the GBs or anyone
Oh, no.
because it is very limited. The 10 minutes can't do a lot of things in it, but I believe it does affect, and it put you in a situation where you have like to review or like book another appointment, but at the same time, the practice can be in capacities, and the next appointment would be a bit further. So I think yeah, the 10 minutes does limit the GB to do to cover all the aspects. Yeah.
Brilliant. Thank you, Mohammed. And Alyson, do you want to come in on that question as well?
Yeah, I think there's a couple of things around that. We certainly hear from people about how sometimes their time in the GP feels really compressed. And if it's a GP that they don't know because they haven't built up a relationship with them over time, then they feel then it takes longer to explain what they need. So I think there's a couple of things that can contribute to making the best use of times. One is information. There's an awful lot, people tell us an awful lot about how they have to repeat themselves over and over again about the things that matter most to them, what they need in terms of their communication needs, what can help them in terms of navigating their way through the system, or the things that matter most to them, as we've talked about. And we don't have, certainly in Wales, the information systems that support GPs to do that very well. So, for example, they don't always have access to all of the information they need. If somebody's had hospital care or care from another part of the system, they don't often or always have that information ready at their fingertips. So patients tell us that they have to spend time repeating a lot of that, where they expect the system to know it, and they expect that information to be available to a healthcare professional at their fingertips, so they don't have to waste that time. And then I think, that then provides more space to listen to people about the actual thing that they've come to talk about that day. The other aspect, as I referred to, that's really important to people when they are receiving care at a GP practice is that trusted relationship. They need to know and feel that the person caring for them understands them and understands their circumstances. So as much continuity of care that is possible in a GP setting is really important to people, and then can help make use of that time, that fairly limited time, even more.
Brilliant. And in Wales, I should know this, Alyson, so if patients feel that they haven't been listened to in their goals and preference, do they have a right to go to ask for a second opinion or to go somewhere else?
No, it's not expressed in that way. They certainly have a right to voice their concerns if they feel that they're not listened to, but they don't have that kind of choice that you're talking about. I think the focus in Wales has always been on voice, and so the conversation has been around people being able to kind of express those things that are important to them, but they don't have that same concept of right to make choices about where they access care and treatment in the same way as they do in England.
Brilliant. Seb, somebody has brought in the NHS modernisation bill, and they've asked to ask your views on how that is going to shape patient engagement and patient care, because the independent patient voice, mainly because you worked at Healthwatch.
Yes, I don't think it'll be a surprise to anyone that I am deeply worried about some aspects of the NHS modernisation bill, and particularly the loss of the independent patient voice function through the Healthwatch network. I think that is a regressive step. And many people on this call I know work for local Healthwatch organizations or have had something to do with them and are well aware of the limitations of the model and problems that it has. But it is the closest thing that we have to a properly independent function, which can hold a mirror up to the system and properly scrutinize from a position of genuine independence. I really do fear that trying to push these functions back into commissioners and providers, particularly in a world where they're under immense pressures, particularly financially, is almost a recipe for them to be cut back as functions. So I'm really worried about direction of travel in the modernisation bill. I think alongside kind of what the modernisation bill says, I think the other thing which I think will be frustrating to many people on this call is the kind of ethos that it represents around patient engagement. So one of the things that we hear a lot about as part of the modernisation bill and its conversation is about the future of patient feedback and voice. And people will say, well, we've got more data than ever before. We've got AI. We can filter through complaints and feedback more quickly. One of the things I really worry about with our approach to engagement at the moment is that it is about collecting more and more information, but ever less valuable information. I think all of us know on this call that the most important thing about patient engagement is deep listening. It's about actually hearing about someone's whole journey through the health system, about who they are as a person, what that experience really felt like. I think the problem at the moment that we've got is that in our push to have a kind of TripAdvisor or Google Maps review style approach to patient feedback, that we're missing the wood from the trees. So I think as well as the kind of what's been set out in the modernisation bill, there's a worrying trend in patient engagement, which is it's all about that metadata and being able to collect more of it rather than it being about genuine listening. And I really hope that if one positive thing comes out of the huge number of kind of patient safety scandals we're experiencing at the moment, it's a proper reflection on where we want to engage patients and how we want to engage them, rather than it being that we could review these things in real time and do it quickly and get some numbers that say that a certain trust is a 4.2 and another one's a 4.0. Really having that conversation about we need to listen to and engage people throughout the entire process rather than in the reactive way that we've been used to for a long time and is only getting worse at the moment.
Yeah, no, absolutely. And I think I agree with everything you said on the NHS modernisation bill. And, within any, AI, digital, they're all fabulous, completely believe in analog to digital, but they are solutions. And if we're not listening, the solution is not going to work. And somebody quoted something to me the other day where that a lot of times kind and compassionate care, because majority of it is kind and compassionate, is sometimes confused with shared decision making and what matters to you. And I think that's the important part of it. Mohammed, I'm going to come back to you. And I suppose Seb in a way has brought up something around kind of how we were designing and delivering services. And I think we need to start with people. We were quoted in the 10-year health plan around actually starting with people to understand. From the communities that you're working with, how would that work, really starting with the person to understand what they need from their healthcare?
Yeah, so I'm not really sure, but I think it will start with something like a focus group or like gathering all their options or like ideas of how like a proper healthcare is and what kind of thing they want to do. Like they want to get treated the way they want and What's the culture like? What's the thing to be considered? What the big factor to be considered like for each of them? And I think it's gonna be like it's a process, like a long process. But yeah, this will be fair, like to include everyone and having like to gather the feedback from all of them. Yeah.
Brilliant. Yeah, and I think that would be it. I think there's other questions. So the questions I've been asking at the moment are ones that have kind of correlated, were brought in when people registered to attend the event, and we've tried to bring them into themes so that we can ask as many questions as possible. But what sometimes you hear is around, one size fits all, but we're all individual. So
Yeah.
how do we address a healthcare system that will be more efficient? It will have better outcomes, it will be more efficient, and it will save money. I think, Alyson, you talked about that earlier, and we looked at our patient partnership principles. That was proven. So how do we start that conversation that actually, if we work directly with people, it will have better outcomes?
So I think one way to go about this is to like, I think it been mentioned before, like awareness, like to make the people like make sure that they're aware how the system works and how could they have their input into the system, like and like a full picture of like how the healthcare works, how you could shape the healthcare, how you are allowed, like what's the proper way or appropriate way to like input your background, your culture. I think an awareness of or like a system will like promote this idea is what's needed, like everyone to understand really what's the NHS system, yeah, about.
Brilliant. Seb, during the pandemic, and towards the end of the pandemic, the Patient Association wrote a letter into the system and said, it showed at the very beginning of the pandemic that you can really transform if you want to, and you want to do it fast. But we transformed the system for the system so that they could provide services. And our argument was, now you need to transform with patients at the heart of it and transform it for patients. Are we still too focused on system transformation?
Yes, short answer. We are too focused on what the system thinks really matters, and I think it goes back to what I was saying in my opening remarks, that the things, particularly for policy making and national decision makers, that are so animating are the 5%. They're like the decoration. They're not they're not the things that matter on the ground. So we spend a lot of time thinking about those kind of hard bits of infrastructure in the system, organizational boundaries, funding flows, service design at a very high level. We don't really think about, if we turn the system around and said, how do we really design services that make a difference to patients? We don't really have that conversation. I think in part it's also, this is a kind of relevant to the point I was making earlier about staff engagement, is it's also true of engagement with staff that we don't really have that kind of comprehensive approach to listening, to say, most of you who went into working in jobs in healthcare did it because you wanted to make a difference, and you did it because you wanted to provide really good care for people. What would it mean to you to be able to do that? Like, what would the organization you work for, the system you work in, look like to enable you to provide really high quality, personalized care to people? So I think there is something about kind of flipping some of our assumptions about what makes a difference in the system and starting from the bottom up, which means engagement with both patients and staff, to really start doing that transformation that makes a difference. Because my fear is that we're going to spend 10 years on transformation, which is going to be about reorganizing the deck chairs in DHSC and NHS England, merging a few ICBs, developing a new generation of advanced foundation trusts. But the real coalface activity of providing care to patients is out of scope from those conversations. So I think it is about having a different starting point when we talk about system transformation.
Yeah, and that's why I think we developed our patient partnership principles, because we really understood the value of frontline staff, and we think it needs to be, front staff and patients working together to create that environment, that shared decision making, that active listening and hearing, can happen, and time is part of that, and culture is part of that, which one of you brought up earlier. And I think one of my favorite words about all of this is curiosity. And I know, Seb, you've been in rooms with me when people have talked about curiosity and having that interest and wanting to understand. So, Alyson, so great that the government, like I said, is going to do what matters to you. But there are a lot of challenges in Wales in terms of cross-border care. The NHS app doesn't work. Works for the bit you're having here. The referral system slightly different. How can we really get to a point that what matters to you is very much part of it when that's the reality for patients on the ground?
I think we need to move away, certainly, from one of the things that happens a lot in Wales, and it goes back to a point that Seb made earlier. When health services talk about patient engagement, too often what they mean is, especially when they're talking about changing the system, they've been getting their views on an approach that the health system has already decided it wants to take. So it isn't actually looking to find out what matters most to people about how their services need to be designed for the future. It's much more about asking questions designed to get them to agree to the answer that's already been predetermined, and we have to shift that. There's lots of, and we have to look at engagement in a much broader way, because people talk about their experiences of their health services all of the time. It's not necessarily about filling in a survey with a set of prescribed questions. Staff hear what people think and feel about their services through every interaction. We need to find better ways of using and acting on what we hear to drive the difference. There's nothing, listening in itself achieves nothing if it doesn't lead to action, and if people can't see that something's happened as a result of it. So if people feel that they feed it in their views and it doesn't make a jot of difference, they're not going to do it the next time, and they're going to really disengage from it. So we have to look more broadly at, I think, what we mean when we talk about engagement, when we talk about partnership, when we talk about shared decision making. And that does have to start with conversations about the things that matter most to people, about their healthcare in their communities. What does that look and feel like for them now and in the future? I'm not sure I answered the question clearly.
You did. I'm writing down a further question. Okay. No, I think that's really important. And I think, I've seen some really good examples where systems have started with patients with blank sheets of paper and said, actually, what is it you need from this service? And then been really pleasantly surprised. And that's how it should start in my view anyway. So we are coming very closely to the end of this. And I think the one question I want to give you a minute or two to think about it is, what is the one thing that we could do differently in order that we can achieve what the start of this webinar was, which is, do patients' goals, values, and preferences really shape their care? How do we achieve that? I think that's a really important question. So have a think about that question. But in the meantime, I'm going to come to you, Seb, so you don't get time to think about this question, to ask you about, we've had so much policy on this.
Mm-hmm.
We've had policies, we've had personalized care, we've had lots of different, we have the NHS constitution. All of these things say that this should be happening. Mm-hmm. What is it the policy could do differently?
I think that the starting point of this is embedded in that reflection, which is we have to be humble about what policy can and can't do. I know Paul Corrigan, who obviously helped advise on the 10-year plan, always says that policy is a feeble instrument. And I think what is meant by that is we obsess over getting the guidance right and setting out the policy. We don't think enough about implementation. But we also don't think enough about that kind of intrinsic motivation, why people do what they do and how you tap into it. So I think often people feel a bit like in this space that they're being like when guidance around patient partnership is produced, often people working in the system feel a bit berated by that guidance. Like they feel like they're being accused of doing something wrong rather than us having a conversation about how do you involve people in a deliberative conversation about what good looks like? How do you make sure that it kind of taps into what motivates them? So I think there's something about humility in policy. I think we overdo policy, and that's professionally worrying for me, given I work in a policy job. But I do think we need to be clear about kind of where policy starts and ends. I think the other thing in that space is kind of I don't think that in our approach to patient engagement and patient partnership, I think often we don't treat patients as grown-up partners. And what I mean by that is a lot of the conversations we're having, and I'm seeing it reflected in the questions on this call, are just about trade-offs, right? So there are questions about everyone wants a longer GP appointment, but in a system where we have limited resource and limited time and multiple competing demands, like some people want quicker appointments, some people want a longer appointment, some people want an appointment with the GP that they've seen for the last 30 years. Some people don't care who they see. We don't really treat patients as kind of constructive partners who we can consult on some of those trade-offs and who can weigh real choices. Like, I think some of this is about having that grown-up conversation and saying, we can't deliver everything. Let's talk to the people who are really affected by this and think about how they would set preferences in the system. Because I think sometimes where the policy doesn't really connect is if you've got policy on infection control and clinical guidance and what you're meant to be doing with patients in partnership and hundreds of bits of guidance coming at you, you never really sit down and filter through that and say, how do I have the conversation about what matters? So I think it's, again, being wary that policy policy has its limitations, and often more policy doesn't mean better policy.
Yeah, absolutely. I agree totally with you. Okay, so Mohammed, I'm coming back to you. So what is the one thing that you think could happen to make sure that patients' goals and priorities and preferences really shape their care?
Yeah, I think it's really important. I think the one thing could happen is to be given, like I said, to be given the space always and to be considered and to really for a fact like look up these facts, look up those like cultures, like different cultures and what being shared. So there should always be a space where you could like shape the healthcare you receive. There should always be space like to accept your input in it. So I think this is the one crucial thing, yeah, which is I know it's tricky, but as a patient, this is what I really want. Yeah, thank you.
Okay, well, that's what we shall strive through because as a patient, that's what we need to get. Alyson, what is the one thing that you think we should do?
So it's following straight on from Mohammed, and I'm going to sound a bit like a broken record, but if I could choose one thing, it would be that every interaction with patients starts by asking what matters to you, and then the answer is acted upon. I know it sounds simple, but it does fundamentally shift the dynamic, I think, and starts the conversation on working with people rather than doing to. If that became the norm in our NHS, then that would make a massive difference for everybody, including those working in it, I think.
Yeah, I agree with you. Seb, can you just go and get that sorted then?
Yes. No, I also totally agree on the kind of starting that conversation in the right place. I think also thinking about goals and values in a different way. What we tend to talk about when we talk about goal setting and values in health is often very clinical things. So people coming along and saying, I want to stop X medication or I want to get my blood pressure under control. The system is comfortable with those kind of goals and requests, but it's not comfortable with things that are about your messy life. And I think there's something about making sure that when we talk about goal setting and values, that it's really reflective of what patients actually want. And that is not always about health or healthcare. So I think it's a kind of power reorientation in the system there, which is really important to enshrine. My other point is just the kind of tokenistic and reactive approach that we have to patient engagement at the moment. It is just, I remember someone saying that our current approach to patient engagement was often not partnership, but insurance policy. We often use patient engagement to cover our backs when things go wrong. I think having a proper forum and using things like, say, the neighborhood health agenda to say, actually, there is a way in which you do this. There is a genuine toolkit and approach that you can use to engage patients in this from the get-go. And we will ask questions about whether you've done that and whether you follow it. I think we should take a similarly somewhat hands-on approach to making sure that these processes are gotten right, because that's exactly what we do in other areas of healthcare and exactly what we do on clinical activity and on finance. If we don't treat patient experience and engagement in the same or a similar way, it will always be subservient to the other things that we care about in healthcare.
Yeah, and that's where it needs to start. So I think for me, a lot of what I've heard there is about, valuing the patient expertise, but also, patients value the healthcare professional, but actually need people to understand and listen to, this is my life and this is what I need to achieve. And one of our trustees, when I was talking about this the other day, was saying the only thing they want, the most important thing to them is being fit enough to play with their grandchildren when their grandchildren get a little bit older. That is it. And that is what they want healthcare for. So, I think that's coming to that point that sometimes it isn't about a clinical outcome or changing a drug or whatever. It's about really understanding what makes you tick. I think I heard a lot about humility, and I think that's lovely. And trust and curiosity. And Mohammed, I think if your example is if we were more curious about each other and we acted in a way that was more humble about listening and experiencing, then I think we could get to a point, and that wider workforce that is there to support your social prescribers, your care navigators, they're there to support that journey, and the voluntary sector, obviously. We are at 5 o'clock. I think we could have talked for another hour on all of this. I hope everyone enjoyed the webinar. Thank you so much for your interaction on the chat and in the Q&A and when you were registering for the webinar. Remember, there are more webinars happening this week, and a lot of them will overlap. Conversations today about trust and communication will come up again on Thursday and Friday. So and I want to thank our funders, and because without that we couldn't have done this webinar. But also I want to remind you of our independence, because that allows us to go out there and challenge the system when it fails patients, but then to also work in genuine partnership with those who really want to get that patient engagement and partnership right. There's numbers there for you. But again, thank you to my panelists for great work and some great thinking, and my brain is buzzing with ideas. And thank you so much to our sponsors.